Today we are going to discuss about the evaluation of neck pain. We know neck pain is little less common than your back pain, but still lot of patients suffers from neck pain, and this is one of the area where we pain physicians give less importance. So in today's lecture we are going to explain the step by step process of evaluation of some patient who is suffering from neck pain. And as you know that history is most important part in evaluation of any kind of pain, be it headache, be it shoulder pain, be it back pain. So here also in evaluation of the neck pain, the history have most important value. So without delay, let us start. So these are the basic steps. One is your remembering the causes and the red flag. Then is your history. In the history, we have the general history and specific history. Specific history means some specific questionnaires which will be asked to the patient related with certain kind of diagnosis. Then your general examinations. General examination is similar for any other kind of evaluation. It starts from the general inspections, palpations, range of movement, neurological examinations and special clinical test. Then certain investigations, X-ray, CT scan, MRI, these are some images, some of the blood investigations and some other electrophysiological tests and some other tests which completes the evaluation. But this part is very important. So this is diagnostic interventions. Even after all these clinical evaluations and the imaging and the laboratory investigations, if still the diagnosis is not clear, then in the hand of a pain physician there is a very powerful tool, and that is your diagnostic interventions. If we are still not sure, it is not clear that where from the pain is generated, what we can do is we can give local anesthetic in the suspected structure one by one, and that can make the diagnosis clear. So these are the steps, and obviously we will be starting with the causes and red flag. Whenever we are evaluating any kind of pain, the causes has to be remembered, and along with that we must be knowing what are the dangerous causes. So these dangerous causes must be evaluated first, ruled out first, and then we should go ahead with further evaluation. So what are the causes in neck pain? So this is the list. Like in any other kind of pain, we have to remember that whenever we are talking about the pain of certain areas, so one is your intrinsic, another one is extrinsic. Extrinsic means the pain is felt in shoulder or neck, but origin is not neck. It might be coming from the chest, it might be coming from the diaphragm, it might be coming from the cervical, the other intracranial structures. So these are the different other areas from where the pain might be still felt in the neck. So this is in the extrinsic cause. And intrinsic cause is what? If the structures in the neck is responsible for the neck pain, then we call it as an intrinsic. So extrinsic is also called as known as the referred pain. So what are the causes? Here again, if you are thinking what are the structures there in the neck, so what are the structures? It can be cervical spine, it can be the soft tissues, the muscles, the nerves. So all these things can be responsible for the neck pain. So one is your spine, so it can be facet joint. Facet joint is one of the very common cause of the neck pain. It can be internal disc disruption. We have to remember that the internal disc disruption is less common, much less common, maybe 1/4 or 1/5 less common than that of the back pain. And we know the reason that here the neck, the cervical spine, the disc is well contained with some uncinate process, the bony projections on the either side, and the cervical disc nucleus pulposus get fibrosed much earlier than that of the lumbar disc. So that is the reason why the internal disc disruption is much less common in the cervical spine compared to that of the lumbar spine. Then your cervical radicular pain, radiculopathy, it can be vertebral fracture trauma or it can be interspinous ligaments pain. So these are the structures within the cervical spine which can be responsible for the neck pain. Then comes your muscles, soft tissues. The muscles, trapezius is the most common myofascial pain in the whole body. Apart from that, some other muscles are there which can be responsible for the neck pain. Then some of the inflammatory arthropathies. Inflammatory arthropathies, they may not be limited only to the joint. the inflammations can be, in a surrounded structures. And as you know, the both rheumatoid arthritis as well as the spondyloarthritis both can involve the cervical spine. So the spondyloarthropathies, we have to remember. Neck then is your Rayford pain, and Rayford pain can be from the shoulder joint, which can be felt in the neck. It can be from the thoracic structures like heart, like the lung. It can come from the abdominal structures. It can be coming from the diaphragmatic or subdiaphragmatic irritations, or some other abdominal pathologies like somebody is having the gallbladder stone. The pain can be referred into the neck or the shoulder areas. So these are the different kind of Rayford pain. So as a whole, to remember the different causes, we should be remembering the bony structures and joints, the spines, the muscles, the soft tissues, the neural structures, which are the intrinsic causes, or it can be the extrinsic causes coming from shoulder, coming from the thoracic structures, or coming from the abdominal structures. Then out of these, we have to remember again what are the dangerous causes, which must be diagnosed very early. And whenever the red flag is present, this is again very basic things to remember, that we must be involving a multidisciplinary team. So in that multidisciplinary team, one pain physician should be there, one neurosurgeon should be there, one rheumatologist, one physical medicine physiatrist. So that multidisciplinary team should ideally take care of a patient when there is a red flag. So what are the red flag? So red flag, like other kind of red flag, one is important is the history of trauma, particularly the major trauma. If it is there, so it's a red flag. We have to evaluate it properly. If there is an infection, if you are suspecting infection, we are suspecting infections maybe by some of the blood investigations, some of the clinical signs, maybe the cardiac signs are positive. So in that way, if you are thinking of the infection, if you are suspecting tumors, sudden oil loss, or already known case, somebody is having the CA lung and now he is having the neck pain. So you have to always think that can it be a metastasis? Then next red flag is your progressive neurological deficits. It can be the motor deficit, it can be the progressive neurological sensory deficits. So this kind of neuro deficits are also red flag. In the neck pain, another very important thing is whether there is a thoracic pathology, any symptoms which is suggesting thoracic pathology, like dyspnea, like chest pain. If this kind of things are there, if there is any associated Horner syndrome, again that might be because of the thoracic pathologies. And if anything which indicating that it can be inflammatory arthropathies, means spondyloarthritis, like ankylosing spondylitis, or it can be rheumatoid arthritis. As I told earlier, that the inflammatory arthropathies, either rheumatoid arthritis or spondyloarthritis, both can involve the cervical spine. So inflammatory arthritis also is one of the red flag. So these are the different diagnoses which are basically the different kinds of the red flag, but these are the outlines, and we have to remember all the red flags to to have a multidisciplinary team to take care of this kind of dangerous diagnosis. Now let us come to the history. As I told already that the history is very, very important. We must be knowing elaborately about all the steps. Here we are not going into the detail about each and every steps. I will be recommending our listeners to see one of the earlier lectures, the art of history taking, where we have elaborately discussed about the different steps of history taking. And here we are little bit cutting short the different steps of the history taking, because already we have discussed in another video. So here the history of the present illness, as I told in the earlier video, that history of present illness is very, very important and the most important part. So after we are having the chief complaints, then the history of present illness, where all these different areas like the quality of the pain, the quantity of the pain, the mode of onset, the radiation, the nature, the character. So all those things are very, very important. I am just skipping this slide, and I will be asking our listeners or viewers to go to our earlier video to have the detail about these steps. Then the other histories like occupational history, family history, personal history, medical history, psychological assessment also by history. So these all steps are very, very important, and I will be telling these two slides the history of present illness and the other different histories are the most important step of evaluation of any kind of pain. So then we come to examinations. In the examinations, general examination means the pulse, respiration, temperature, the gait, habitus, how patient looks, orientations, all this in the general examinations, and then special examinations on the neck itself. And it starts from inspection, palpation, range of movement, neurological examinations, and special clinical tests. So, we will be coming step by step about all these different areas. So, first we start with the general examination. General examinations, apart from the pulse, respiration, temperature, which are also very important, one very important aspect is gait, how the patient is walking. And you know, in the cervical myelopathy, the patient's gaits changed, it's a reeling gait. Patient cannot walk in a straight line. Then how is the body habitus? How is the the higher functions? By some simple question about the orientation of the date and time, some of the short term and the long past memories with which we can understand the higher functions. Then come to the examinations, and examinations start with inspection. So in the inspections, we should look for the skin, if there is any scar mark, if there is any swelling, head and neck posture, whether it is straight or it is tilted to one side, whether there is a shoulder symmetry or there is asymmetry that indicates some of the radiculopathy, muscle wasting, if it is there in any part of the neck or in the shoulder part, if there is any muscle wasting, even the wasting of the deltoid, the biceps, these muscles also should be inspected to have some muscle wasting or not. Then your tenderness, palpation. Tenderness is very, very important to identify the pain generator. So, where is the tenderness? So, that can be giving some very important clues to understand that what might be the possible pathologies. And in elicitation of the tenderness, it is very easy to remember that we will be palpating the bony structures, the joints, as well as the different soft tissues. And also, we will be palpating anteriorly and we will be palpating posteriorly. So, the very important causes of the pain is your myofascial pain in the neck. As I told that the trapezius myofascial pains and some other the neck extender muscles are very common source of the myofascial pain. So, you have to individually palpate all the muscles. We should be palpating the different ligaments like interspinous ligament, supraspinous ligament. We will be palpating the joints like facet joints on the either side. You should be palpating the different nerves like occipital nerves, you can palpate against the occipital bone. So, these are the different ways. So, anteriorly, laterally also to palpate the facet joint, and posteriorly also different bony structures, the nerves and the soft tissues. So, palpation carries very important value to understand, to have some idea about the location of the pain. Next step is your range of movement. In the range of movement, we have to see both active and passive movements. And as you know that when the active movement is restricted but not the passive, it is normally the periarticular structures are involved. And if both active and passive joints are active movements are involved, then that means it is the intra-articular pathologies. So, similar kind of things are here, and we have to see all the movements in the neck like flexions, like extensions, like rotations, like the lateral bending. So, all these structures we have to remember. One thing that is very important difference between the lumbar spine and the cervical spine that we have to remember, that for the loading of the facet joint, we know in the lumbar facet joint the movements are extensor, the lateral bending and rotation, these three movements, and extension is most important movement for loading the lumbar facet joint, but here for the cervical facet joint extension is not that important. So, here important is your lateral bending and rotation which loads the cervical facet joint. So, all those the movements are important. Then is your neurological examinations, and here it is very important that we should be doing all the cranial nerve examinations. So, this is quite common in the different kinds of in the neck pain. So, you cannot miss out these things, and in the cervical nerve roots you have to again see sensory, the motor and the reflex areas. So, in the sensory we have to remember the dermatomes. So, if whether the pain or the numbness is along a dermatome or not, and how to remember C1. C1 is a very small area, sensory areas is almost not there at the nape of the neck if it is there. Then is your C2. How to remember C2? So the occipital area, if you are dividing the whole of the occipital area, the medial half of the occipital area is C2 and the lateral half up to the mastoid process is your C3. Then C4, from this mastoid, the neck up to the tip of the shoulder is your C4. Then from the lateral aspect of the arm up to the elbow is your C5. C6, lateral aspect of the forearm up to the thumb. C7, the middle 3 from anteriorly as well as posteriorly. Then you have C8, C8 is the little finger and the medial aspect of the forearm, and T1, medial aspect of the arm. So this is from the back and this is from the the front. So this dermatome is very important. This will be telling us where is the pain, which will be giving us some important clue about the which dermatome or which nerve root might be involved. Then is your myotome or the muscles. So these are the certain movements which are very important and this will be giving you some overall clue about the which nerve root is involved. C1, forget it, don't have important the motor supply. Then is your coming the C2. C2 is your neck flexion. Then your C3. C3 is neck side flexion. This is your C3. Then C4. C4 is shoulder shrugging, shoulder elevations. And this has to be done against the resistance, like in the lateral flexions, like flexion of the neck. So all those things should be done against the resistance. Then your C5. C5 is the abduction of the arm by majority of by the deltoid. Then your C6. C6 is the flexion of the elbow. Then the extension of the elbow is your C7. Then C8, gripping, small muscles of the hand, and T1 is your fanning of the fingers. So these are certain basic movements with which we will be having some idea, very important clue about which myotome is involved, by which we can understand that which nerve root is actually involved. Then your different reflexes. These 3 reflexes are very important. One is the biceps. Biceps is C5, 6, but for the ease of remembering, we can remember it is C5. Both C5, 6. Brachioradial is both C5, 6, but it is easy to remember that this is C5, this is C6, and this is C7. So 5 is your biceps, 6 is your brachioradialis, and 7 is your triceps. So these 3 jerks we can elicit and we can have some ideas. And next come your special clinical test. Special clinical test is again very important, and these are the list: Sparling test, relief sign, neck destruction test, Valsalbel's maneuver test, Lermite sign, Jackson compression test, and Adson maneuver. So we'll be coming to each of these special clinical tests one by one. First, this is your Sparling test. So Sparling test is very specific for the nerve root irritation. So what do we do here? We are trying to reduce the size of the foramen by lateral flexion. So what do we do here? So examiner is standing behind the patient and passively, this is again very important, passive lateral flexion. Remember, don't press it too much, just passively push it and try to make the foramen narrower. So if the nerve root is involved, then the patient will be having the pain along those dermatomes which roots are involved. So this is the Sparling's maneuver or the Sparling test. This is specific for the nerve root irritation, but it can also be positive in facet joint arthropathies, because when you are doing this, as we told earlier, that facet joint in the cervical area is best loaded with lateral flexion. So that means when we are doing the Sparling test by passive, the lateral flexions, our facet joint is loaded and it can be coming positive. Next special test is your relief sign. So what is relief sign? We are asking the patient to elevate the affected side, to keep the hand over the head, and if the pain is there, so that pain will be relieved. How? This is again important for the nerve root irritation. So when we are doing it, so nerve root is relaxed. When the hand is hanging, then the nerve root is stressed. So the hanging position, the patient feels more pain in cervical radiculopathy than if there is doing that means nerve root is relaxed, relieved. And another very important things to remember, particularly when there is this neck pain, shoulder pain, arm pain, one of the very important differential diagnosis is your shoulder pathologies. Shoulder pathologies can be ruled out. Most of the shoulder pathologies, if it is there, the patient is unable to do like this. That means if the patient is doing like this, pain is aggravated, means it is shoulder pain. If the pain is relieved, that means it is cervical nerve root pain. So this is your relief sign. Next is your distraction test. So what is done here? The examiner's patient is sitting like in a chair or stool, and the patient is standing. Examiner is standing behind and elevating like this. One hand in the chin, another hand in the occiput, and elevates. But what is very important is you have to keep that elevated position for 30 to 60 seconds. It's not that you are lifting and releasing it. You have to keep it in that position for at least 30 seconds. And what will happen if you are elevating like that? So we are basically distracting, and we are the foramens are decompressed, so that the nerve root compressions, which is nerve root is coming out of the foramen, they will be decompressed and the symptoms will be relieved. If the radicular symptoms is relieved, that means distraction test is positive. And another very important thing to remember, if you are doing the distraction, what is happening to the joints? So joint capsules are stressed. So if there is inflammation, suppose somebody is having the rheumatoid arthritis involved in the cervical spine, so that pain might be increased. So if the neck pain is increased, it is most likely the joints in the cervical spine is involved. But if the radicular pain is relieved, that means most likely that this patient having the radicular symptoms, radiculopathy. There is Valsalva maneuver. So what is that Valsalva maneuver? We simply know that you press your patient's neck, nose and the mouth and ask the patients to exhale. So it can be done by this way also, putting a thumb there. But again, the closing the nostrils, closing the mouth and try to forcefully exhale. So what will happen here? If the patient is having some space occupying lesion, large prolapse disc, so those kind of, the large intervertebral disc prolapse herniations or some spinal tumor or tight stenosis, the symptoms will be reproduced, and that is the Valsalva's maneuver, Valsalva test, which can be positive. Then you your Jackson's compression test. So Jackson's compression test is what? So here you see the patient's neck is rotated and the patient is, the examiner is standing behind, neck is rotated and it is passively pressed. And here this is mostly rotation plus lateral flexion is equal to what? Is equal to facet joint. So this test is for facet joint. But again remember that when rotating and the flexing, lateral flexion, then the root is also getting compressed. So Jackson compression test is more specific for the facet joint, but it can also be positive in the radicular symptoms. So if the patient is having the neck pain, then it is facet. If it is a radiating pain, then it is the radiculopathy or radicular pain. Then is your Larmit sign. So what is done in the Larmit signs? In the Larmit signs, passively examiner is flexing the neck, and again if the neck is flexed, if there is a space occupying lesion in the cervical spine, tight cervical stenosis, then the patient's symptoms will be reproduced. Then comes Adson's sign or the Adson's maneuver. So this is for thoracic outlet syndrome. So if the patient is having anything, thoracic outlet syndrome or maybe the cervical rib, so what will happen? The brachial or radial pulse will be getting reduced. And this is how it should be doing. Patient is flexing on the affected side, extending the hand, and examiner is palpating the radial pulse and asking to inspire, the full inspiration. During the full inspiration, this pulsation of the radial artery will be diminished, or even we may not be able to palpate the radial artery pulsations. So that means it is positive, and it is positive in thoracic outlet syndrome. So these are the different the conditions, the special clinical test, which is having the very high sensitivity and the specificity, and this will be very useful in our day-to-day clinical practice. So after that, this is a very simple algorithm. If somebody is presenting with the neck pain, first thing to do is your rule out the red flag. If the red flags are ruled out, then we have to ask the patient whether it is only neck pain or whether it is neck pain with the hand pain or whether it is neck pain with the headache. So, only neck pain with the hand pain or neck pain with the headache. So, remember that cervical spine pathologies, if it involves the upper cervical pathologies, it is very common to present with headache, and we know that this is called cervicogenic headache. So, pathology in the cervical spine, but patient presents with headache, or if it is the lower cervical or middle cervical, then there is a possibility that the neck pain is associated with the hand pain. So, we are dividing neck pain with headache with hand pain, or it is only neck pain. So, if it is only neck pain, the next question to be asked, is it midline, axial, or is it paramedial? If it is midline and axial, then you palpate whether we are eliciting tenderness in between the two spinous process. If it is in between the two spinous process or over the spinous process. If it is over the spinous process, it can be IDD, internal disc disruption, but remember that the IDD, internal disc disruption, is your less common. Here the pain will be aggravated more with the flexion of the neck. Then whether the tenderness exactly over the spine as well as the little bit of paramedial tenderness, it can be bilateral facet joint on the same side, and here the flexion will be relieving the pain. Then the midline pain in between the two spinous process, then that can be because of the interspinous or supraspinous ligament sprain or enthesiopathies. So, this is the axial neck pain. Then if it is paramedial neck pain, then paramedial neck pain, the two most common reason, one is your facet. So, the facet loading will be positive, Jackson compression test will be positive, rotations and the lateral flexion will be aggravating the pain, or it can be myofascial pain, mostly trapezius. So, do the opposite movement, stretching, then the pain will be aggravated. So, if the opposite side movement is increasing the pain, then it is myofascial pain. If same side pain is reproduced, then it is your facet joint pain. Then the neck pain with hand pain. Now, we have to ask the patient whether the hand pain is involving the whole of the hand in a global distribution, then the most likely it is your CRPS without any pattern, whole of the hand. Sometimes it can be because of the particularly the gloves distribution, it can be diabetic peripheral neuropathy as well. Then is the patchy. If it is patchy, whether it follows a dermatome or not. If it is dermatome, then it can be PIVD, prolapse intervertebral disc, it can be post-herpetic neuralgia, or sometimes it can be diabetic mononeuropathy. These are the dermatomal involvement. If it is non-dermatomal involvement, then you look whether it is following a pattern of a nerve distribution or not. If it is a nerve distribution, it can be the median nerve entrapment, it can be ulnar nerve entrapment in the elbow. So, you just follow whether this is a nerve entrapment or not, or it can be completely patchy, not following any nerve root. Then it can be a referred pain coming from the facet joint, myofascial pain, or similar kind of things from the other areas, other structures, it is coming referred pain. So, that is not going to follow any of the nerve distribution or any of the root distribution. Then come your neck pain with headache, we call it cervicogenic headache. So, one is your limited neck movement, the dialacking kind of pain, and there is trigger points, then there is myofascial pain. Then is if sharp shooting pain along with the distribution of the greater occipital, lesser occipital or third occipital, then it is occipital neuralgia. Then if the pain is well localized, mostly on the one side, getting the local tenderness, getting the Jackson compression test positive, then it is cervical facet joint, and it sometimes can be migraine also. It is not cervicogenic headache, but it is not uncommon that in migraine patient is having the neck pain as well as the headache. So, typical characteristics of the migraine headache like pulsatile, the very severe headache, changing its side, sometimes right side, sometimes some attacks left side. So, with this kind of criteria of the migraine, we can diagnose the migraine as well. So, this is in short the very simple algorithm with which we can have some ideas about the neck pain. So, we have not discussed about what are the investigations to be done here. we have restricted here with our clinical methods, and thank you very much for watching this video.